If I could ask everyone to find a seat, we'll try and get started. Okay, good evening everyone and welcome to our second GE Society of Queensland dinner meeting for 2019. Those of us who braved bad traffic, poor weather, and everybody at home watching on the webcast. We've got two esteemed local speakers tonight, David Cavalucci and Dr. Matthew Burge, who are both experts in the surgical and oncological treatment of pancreatic cancer. In addition to that, firstly, I guess we should thank our sponsor, Gilead, for supporting tonight's meeting. They don't do anything specific for pancreas cancer, but I guess from our perspective as gastroenterologists, for which the majority of the audience are tonight, we see a lot of hepatitis C, and it's changed and revolutionised treatment, I guess, in the past few years. So regarding our two speakers, Dr. Cavalucci will be kicking off and talking first. I'll give him a little bit of an introduction. He sent a long spiel, but I'll try and keep it short. He's a hepatobiliary surgeon, hepatobiliary pancreatic surgeon based at the Royal Brisbane Hospital, who performed robotic as well as laparoscopic liver and pancreatic surgery. His interests primarily have centred around HPB, and he's done fellowships locally as well as at the University of Toronto. He practices primarily at the Royal Brisbane Hospital and has private practice at the Wesley. David's active in teaching. He maintains a strong interest in clinical research and is a member of the local boards as well as the Australian and New Zealand HPB Association. I'd like to welcome David tonight to commence. He'll discuss pancreatic cancer treatment from a surgical perspective and give us a current update. Now, following his discussion, we'll have main meal served, and then Matthew Burge will speak. Well, I'll try and leave questions towards the end because there may be overlapping themes. Okay, thanks, David.
Thanks, Jason, and thanks very much for having me here and seeing so many familiar faces and friendly colleagues out there. I'm going to try and focus mainly on things I hope will be a bit interesting and show a few videos of surgical stuff because we can't help ourselves. I do some paid proctoring stuff, but nothing that should interfere with today. But also I know there's a lot of variety in both experience and clinical practice with the gastroenterologists who are here. So I do apologise if I've aimed it too high or low, and it's certainly not intentional. I just want to talk about a couple of cases in the sort of preoperative multidisciplinary setting that we have, where we all see in pancreas cancer, and then have a look at some surgical advances. One thing that was a big deal sort of back in 2017, and this is when the European guidelines came out for sort of management of preoperative biliary drainage. And at the time, there had been sort of a bit of conflict, I guess, between the surgical sphere and the gastrosphere. And I think we all kind of just got together and figured out that generally, most patients probably don't need drainage unless they've got complications. If you are going to drain them, put in a metal stent, and that kind of works. But then, sorry, gone the wrong way. So generally, we would certainly favour that as a surgical approach. But the problem is now, and especially with what we're going to talk about tonight, is that now, internationally and especially Brisbane-wide, we really have a protocol now that most, or if not all, patients who've got pancreas cancer or suspected pancreas cancer should have neoadjuvant chemotherapy. And what that means is, number one, we need tissue, which generally means an ERCP. And of course, if you're going to be there, that generally means then a stent. So I think whilst those guidelines remain relevant, now hopefully at this stage we're going to try and push really hard for everybody to get ERCPs, stents and tissue. In the palliative setting it's a little different, of course. I think strongly now we would favour ERCP where possible over PTC. Hopefully there's not too many people being sent for primary PTC for management of this. But the one big thing that's come up a few times, and there's a trial going on down in Melbourne, is looking at is actually there a role for surgery again? Because these patients with good chemotherapy are living longer than a year, sometimes longer than 2 years, even though they've got unresectable cancers. And whilst stents are amazing, they don't sometimes go the distance. So is there a role again for surgery in that space? But that's still coming. So what are some of the problems we have, or what can be some of the issues that we have in this multidisciplinary approach to pancreas cancer? And one of them is one of the things that Nick O'Rourke likes to call the dangers of heavy petting. And this is a patient of mine who came in with a gastric outlet obstruction from a duodenal cancer or a head of pancreas cancer, and his PET scan showed positive nodules in the neck. And he actually got referred to one of our gastroenterology colleagues, who may or may not be in this room, who shall remain nameless, Remedios, and had a duodenal stent placed because he was deemed unresectable because of his neck nodes. So he went on and had a lovely duodenal stent, and then was in ICU the next day with severe pancreatitis, unfortunately. Now, 4 months later, he'd had 2 necrosectomies in the ICU. While he was under anaesthetic, we'd biopsied a neck node, which was negative, and he actually ended up having a Whipple's. And he's still alive now, and that was nearly 6 years ago, from what was a resectable cancer, who had great treatment with adjuvant therapy. And that's not having a go at Matthew. That's one of the things that sometimes, you know, you need to MDT sometimes with groupthink. I think we all kind of go, yep, and we vote for an option, and you know the MDT gets it wrong, and it's incumbent upon all of us who do technical work like this that we don't just be the technician and go, oh yep, I'll do that. We have to check and recheck. We have to try not to do things that are completely irreversible for our patients. So, you know, duodenal stents, which are non-removable, it's a one-way ticket. You know, we have to try and keep as many options open as we can. And you know, the MDT is sometimes wrong. So distal biliary strictures is where we can't get a diagnosis. So this is, you know, something that we all hate managing and trying to figure out. And this is another case that I shared with one of our colleagues in the room, who shall remain nameless, Dr. Lee. 69-year-old bloke who came in with jaundice, but just mild jaundice, just slightly 30 or 40, but a lipase of 1100. And changes which didn't really look like a cancer. He just had these funny sort of lobular changes in the head of his pancreas. So he had an ampullary biopsy which just showed inflammation. Great. We sort of thought, oh, look, you know what? This might just be autoimmune pancreatitis. It all looked a bit funky. Let's try some steroids. Sonny said to me, you know what? I still reckon he's got a biliary cancer or a pancreas cancer. I'm a bit worried about giving him steroids. I said, no, let's give him steroids. So we gave him some steroids. His bili halved within 24 hours, and I was patting myself on the back. Then he got severe cholangitis. Sonny tried to do an ERCP then, but it was too late. His ampulla, he just couldn't get back in now, had to have a PTC. Did an EUS, showed, again, just inflammation, fibrosis. And we're thinking, geez, what's going on, this poor bugger? And then unfortunately, post-EUS and biopsy, he got, again, severe, horrible pancreatitis. So August, we saw him initially. He went home in November, and you know, it's really those times when you start to wonder, you know, what are we doing here? Have we done the right thing for this guy? So we restage him later on in the year, about December, and he's got you know, a bulky uncinate cancer. And Sonny was, of course, right. And I think the lesson there is, these guys all have a very high pre-test probability of cancer, don't they? I mean, a 69-year-old with jaundice who's got a biliary stricture, yeah, we might hope that it's going to be autoimmune, but realistically, you know, we've got to have a high test probability. I think you've got to have a red line. You've got to say, okay, when's enough is enough? You know, how many times are we going to biopsy this damn thing? You know, I shared another lady with one of our colleagues. We must have ERCP'd and biopsied her 3 or 4 times over 6 months, never getting cancer until she got cancer. So I think you need to draw a line. We're trying, you know, and again, try not to burn our bridges with what we're doing. And we all share the love with these kind of patients. So what about some cool surgical advances now that we've shown how bad a job we can do? I mean, robotics is probably the big incoming thing. You know, I know there's some robots looking at colonoscopic stuff and endoscopic stuff as well. And the robots are getting pretty fancy. These things can do pretty amazing stuff. And not just in this kind of space, it's also, you know, obviously in the surgical space. But one of the things we always have to be careful of is that for every enthusiastic early adopter like myself, there's contact with the real world, and these things look amazing on paper, but stick it in the real world situation, give it things that don't match its programming, and watch everything go to shit pretty quickly. And the other thing is, is it really new? Do we really need to reinvent this particular wheel? We have a good treatment for this condition. Is this just adding ridiculous levels of technology and complexity for no good reason? So if we look at, for example, the distal pancreatectomy, there's only two operations we need to talk about in the pancreas, distal pancreatectomy and Whipple's. If we look at distal pancreatectomy, it's really a tale of progression to now mainly minimally invasive management of even quite advanced cancers. So open surgery, we still do, of course, but laparoscopic and robotic surgery has really taken off in this space. One of the main reasons of this huge rise, as I'm sure you guys see in your practice every day, is cystic lesions in the pancreas, of dubious malignant potential. And so we look at doing splenic preservation where possible. So there's two ways of doing that. One is the way on the left here, which is to take out the distal pancreas, peeling it off the splenic artery and vein and preserving those vessels and the spleen. And the other way is the way on the left-hand side, which is the Warshaw technique, which is to actually just cut the artery and vein and let the spleen live off the short gastrics and hope for the best, which doesn't seem like a great idea, and in practice it's also not necessarily a great idea. They have reasonable rates of splenic infarction and pain. They have reasonable rates of gastric varices and sinistral portal hypertension at 6 months and a year. They don't tend to have bleeding varices, but certainly, having said that, we don't have a lot of follow-up with a lot of these patients. So ideally what you want is, what's a technique we can use to allow for distal pancreatectomy with splenic vessel preservation as well as splenic preservation. And this graph you don't need to look at detail, except to say that most studies have shown that robotic distal pancreatectomy has much higher rates of splenic preservation. So if you look at the data in this space, there's been lots of non-randomised comparative trials, lots of meta-analyses. This year we're lucky enough to have a good quality randomised trial from the Netherlands, which looked at laparoscopic versus open distal pancreatectomy and really showed equivalent outcomes oncologically, shorter length of stay, reduced blood loss, less gastric emptying, and there was no increase in cost. And so the Netherlands did this trial because they realised that they were only doing 10% of distal pancreatectomies laparoscopically. Now, to give you an example, in Brisbane, we do 90% laparoscopically, and they were wondering why. And, were they missing out on good outcomes for their patients? And the answer seems to be yes. What about the robot? Well, distal panc is actually a really great niche operation for the robot. It's a pretty fixed position. The robot sometimes doesn't have as much flexibility for moving around the body as you can open and laparoscopically, and you end up having to be quite focused on a quadrant. And so for this, it's perfect. We're stuck in the left upper quadrant. We've got lots of fine vascular dissection, so you can see that the robotic arms have wrists that move, they go around and about, so they feel much more like using hands instead of what we call straight sticks, which is laparoscopic surgery. You can't move the ends of the instrumentation, so you end up having to use torque and leverage, which is not always a nice thing to do. And you can see here, we're dissecting out, this is the splenic vein, just digging the pancreas off the splenic vein. Just for the purpose of this course, I made a hole in it so you'd see how we can fix it. But to give you an idea of size, so this is about 10 times magnified. The view we get through the robot is three-dimensional, about 10 times magnified. And the nice thing about it is you can stick, that was a little tiny Raytec, which is about this big, push it on the vein, and then you can actually walk away from the robot and it'll hold everything exactly where you put it. So you can go and change your trousers, have a coffee, come back, and then you can stitch up this tiny little hole with a very fine suture that's 6/0 that you would, difficult to see without magnification, and then you can keep plodding along. And the splenic vein has lots of tiny branches to the pancreas, so unfortunately this is common. If you want to preserve the vessel, you end up making lots of tiny little holes all the way along it, and this way is a nice way to preserve the main vein. So currently most patients would get a distal pancreatectomy minimally invasively, except where you've got some relative contraindications there. So Whipple's procedure is a slightly different prospect, and perhaps minimally invasive Whipple's is a little bit like lipstick on a pig, but we'll talk about it anyway. For pancreatic duodenectomy or Whipple's, open really still is standard of care. I mean, I don't think there's few people who would argue against that, even the enthusiasts like me. Laparoscopic approach to it is definitely feasible, and we do it. but it's really not ready for prime time and wide dissemination. And the robot's the same sort of story, and the robot has a disadvantage also of not being anywhere near as accessible. What is Whipple's? Well, it's removing the head of the pancreas. So this is the head of the pancreas. We also take out the antrum, duodenum, first bit of the jejunum, bile duct because it goes through the head of the pancreas, sometimes a bit of vein if it's stuck, and then we join everything back together. So you get a pancreatico-jejunostomy, hepatico-jejunostomy, and gastro-jejunostomy. And so whenever our nice gastro colleagues are endoscoping these patients post-operatively, they always go, when I get to the end of the stomach, do I turn left or right? And it's usually right to get down back to the pancreas or the bile duct. So why bother doing it minimally invasively? Well, the main reason is that's what lap Whipple's looks like on day one. They go home quicker when everything goes smoothly. They get back to whatever they want to do. Their Pilates within 4 weeks. They do much better as long as everything goes smoothly. And the view is amazing. The pancreas is a retroperitoneal organ. When you operate through the abdomen, it's actually quite difficult to get a view of the back of it. Whereas laparoscopically, you can see and robotically, it's the same story. This is the vena cava, the left renal vein, the superior mesenteric artery just skinned off to get the pancreas off it. And then up the top, you can see a view of the portal vein and the superior mesenteric artery again there. So the view is amazing. Uptake is really slow with minimally invasive pancreas surgery, though, with the Whipple's. And really around internationally, the published level of cases is still well under 1,000. In Australia, we just published our first series of actually 2 years old. It was about 30 then, it's about 50 now. And there's not many places around Australia who are doing it. One of the reasons is it's a complex operation, not just like a distal. There's not just the extirpative part, there's a reconstructive component, and the outcomes, the risks are high. 1 to 2% mortality, varying even up to 15% mortality depending on the centre. Reoperation rate of 5 to 10%. They're not things to snuff at. And then the problem is if you are good at it open and you want to do it lap, you still have another learning curve to go through. So there's another 40, 50, 60 cases. And in the Australian context, we have a relatively small population for our area. We have spread out centres. It's very difficult to concentrate, although we are trying. And so it's challenging to get that case throughput. And I'll just skip those bits. But and again, straight to the videos because they're much more fun. So the robot in Whipple's, the nice thing is in reconstructive things, you get this lovely wristing, stitching. This is the cut surface of the pancreas. Here, the neck with the pancreatic duct, you can see there. This is the jejunum that we're anastomosing onto. That thing thumping away in the background there is the stapled end of the gastroduodenal artery. So you can see why that bugger bleeds all the time, because it's right next to the anastomosis. And when all that lovely pancreas juice leaks onto it, it just explodes. And the view you get doing this robotically is pretty amazing. And one of the things you can see here is this stitch here is a silk stitch. It's a 2-0. It's quite a ropey, chunky stitch. And we put it all the way through the pancreas. And the reason the pancreas is like sweetbreads, it's feathery and soft. If you try and just stitch one bit of it, it just tears and breaks. So you can see these stitches go all the way through, and they really just act as a buttress to hold it in place. Until you can get to the next bit, which is actually joining that tiny little pancreatic duct onto the small bowel. And you'll see here now, this suture is even finer. You can barely see it even with 10 times mag. And that little hole there is about 3 millimetres across. And you can see the view here is pretty phenomenal with the robot. One of the other advantages, and I'm nearly done here, is that up in the top corner here, this is a laparoscopic hepatico-jejunostomy sped up to 4 times. Down the bottom is a robotic hepatico-jejunostomy, same operation, sped up to 4 times. You don't need to, don't worry about the details of it, but just look at the screen and go from one to the other and see which one makes you seasick. And this for me is one of the real selling points of the robot. Down the bottom there, it looks sped up, but it doesn't look jittery, jaggedy. You don't almost vomit just watching it. Up here, you've got your registrar holding the camera in and out, up and down. You're all over the place, and you have to remember that you're compensating for that over a 6-hour operation. And this has got to be better for you in the end, doesn't it? I mean, this has got to be better for the surgeon. I'm not sure necessarily it may make not a huge difference for the patient, but it's got to be better for the surgeon. Because I can tell you, after a 6 or 7 hour Whipples, it's really sorry to throw back to the 80s movies, which probably many of you weren't born then, but and again, the learning curve for the robot is about 80 cases, because you got to learn a whole new kettle of fish all over again. One of the nice things about the robot, though, is you can watch it. And the Americans did this lovely study where they got first-year med students to watch videos of surgeons doing Whipples on the robot. And with almost no training, the med students were able to predict the outcome of the Whipples in the sense of what was the risk for leakage, because they could tell how good or bad it looked. If it looked crap, it was pretty crap, and patients did poorly. If it looked great, patients tended to do really well. And so if a first-year med student can figure that out, then it's really good for us to be able to see and watch our fellows and train and learn. And very quickly, because I'm going over time, sorry, this was our initial publication of our Royal Brisbane data. And you can see one of the things with this is that compared to the totally robotic, and these are the two laparoscopic, so totally lap and hybrid, which is laparoscopic removal and open reconstruction, the totally lap group really do have much higher rates of problems, especially, and this is our learning curve data. The morbidity is essentially double. The mortality stays much the same, but the morbidity is much higher, and that's very hard to sell to patients. And that's one of the reasons why totally lap Whipples I do less and less. I tend to do hybrid Whipple, and then all robotic, and I tend to avoid the pure lap because I don't think the outcomes are as good for me as if I do it the other way. Wrapping up with just one quick case for neoadjuvant, because hopefully it'll segue into Matthew's talk. And this is, all that technical stuff is lovely, but to be honest, that makes almost no impact on most patients' long-term outcomes. The thing that really matters and the thing that really makes a difference for patients, and the only thing that we're actually excited about with pancreas cancer is neoadjuvant treatment, and good adjuvant treatment, to be honest, having an effective chemotherapy agent. And FOLFIRINOX has been one of those drug combinations which has shown up, and this was in the New England Journal, I think it was either this year or last year, which just showed in the adjuvant setting a huge benefit for FOLFIRINOX in survival outcomes. And to give you an idea of how that translates to clinical practice, this is a guy in his late 60s again, actually normal LFTs but pain, with a 2.8 centimetre tumour in the uncinate here, EUS and biopsied without pancreatitis, thankfully, showing an adenocarcinoma. 6 cycles of FOLFIRINOX, 6-week wait, restaging, post-treatment, very small remnant tumour, but still there. And then post-operatively, he had a total pancreatectomy for other reasons, but this was his specimen. T1 tumour, node negative, even despite having bulky nodes on his initial scan. And he had pan in through his ducts, so that's why he had the total pancreatectomy. And the residual tumour was under 1 centimetre. So, it's a big change. We get evidence on histology that this stuff is working, and it makes us, feel more encouragement about treating them. And just a last nod to robotic failures, unfortunately, but this actually is a French robotic arm, which clearly not working very well. Thank you.
On to a couple of quick questions. Thanks for an excellent presentation and demonstration of surgical dexterity, David. I'll kick off a quick question. How does the impact of post-ERCP pancreatitis influence your ability to resect and operate and timing?
Yeah, so it's hard. I think one of the good studies shows the rates of preoperative pancreatitis from ERCP is about 10 to 13%. It's actually not that low. And what it generally means for us is a wait, so it's minimum of around 6 weeks to 3 months, depending on how severe the pancreatitis is. I mean, mild pancreatitis doesn't really make a huge difference, but anything more than that, it definitely impacts. So it's about up to 3 months wait before we can operate. And the data definitely shows that if you've had significant pancreatitis post-procedurally, they get more intraoperative infections and more intraoperative complications and have a longer length of post-operative stay from their Whipple. So it makes a big impact. Having said that, we obviously realise that there's not a great deal you can do to prevent that in this particular setting? I mean, obviously there's things you can do to minimise the risk, but in these patients, sometimes with tight strictures and challenging anatomy, I mean, we heckle, but we realise that there's limitations in what any of us can do, really.
Any other questions? Any other questions after? Yeah, we can. We will afterwards as well. Okay, thanks a lot, David.
Thanks.
Do you need this? So we're going to have dinner, I think, before we get Matt to talk.
Do you want to use this, or do you want your own laptop? Or
I think he's already put it up.
He's already loaded.
today. They don't see things the same. Two walk like two out the door. There you have magic. One comes around, one today. They don't see things the same. Two walk like two out the door. There you have magic. One comes around, one today. They don't see things the same. Two walk like two out the door. Then you have magic. One comes around, one today. They don't see things the same. Two walk like two out the door. Then you have magic.
Okay, we'll keep going. I'm going to introduce Dr. Matthew Burge for the second presentation. Now that everyone's full and had a couple of drinks. I'll just wait till the conversation settled a little bit. So Dr. Matthew Burge is a medical oncologist based at the Royal Brisbane Hospital with a strong interest in gastrointestinal malignancies. He trained as a medical oncologist in Brisbane before travelling to the UK for a fellowship in GI cancers. He returned to Brisbane in 2006. He's currently a staff specialist at the Royal Brisbane Hospital, Prince Charles Hospital and Rockhampton Base Hospital. He has a private practice where he visits the Rockhampton Mater Hospital and practices also at Icon Chermside. We're privileged tonight to have Dr. Burge present his summary of chemotherapy for pancreatic cancer in 2019.
Yeah, thanks very much for the kind introduction, and yeah, thanks for having me. And I hope to instill maybe a little bit of optimism into you tonight with regards to pancreas cancer, but it really is a formidable disease, as you know. But I hope to show you that we are making at least some progress as time goes on, and I think that the future is looking a little bit brighter. The problem being that, as this graph shows you here, it's going to become more and more common and a bigger cause of cancer-related deaths as time goes on. So it's projected to become the second biggest cause of cancer-related deaths behind lung cancer over the next few years due to the progressive rise in incidence and basically everyone who gets it dying of it, maybe 90-95% of patients. So I'll start off the first couple of minutes talking about metastatic disease. So from a historical perspective, chemotherapy with gemcitabine became the standard of care in 1996 based on a relatively small randomised study which showed a few weeks survival advantage over an older way of giving 5-FU, but patients also maintained their weight a bit better, felt a bit better for a while, and on that basis that was our standard chemotherapy from then on. And then you go to ASCO every year from 2005, 6, 7, 8 and hear about a randomised phase 3 trial of gemcitabine versus gemcitabine plus something else, and it was always negative. You came away with gemcitabine alone as remaining as a standard of care, median survival stuck at about 6 months in every single study. And all the other drugs that were working for all the other cancers didn't work in pancreas cancer. And then the French had a great idea of just repurposing some old chemotherapy drugs and sticking them all together. So irinotecan, oxaliplatin and 5-FU, drugs we've been using against colon cancer for years. And they put the three of them together and conducted a randomised phase 3 study of that regimen's called FOLFIRINOX versus gemcitabine. And that actually showed a significant survival advantage, quite to, I think, even to their surprise. And at the same time, or just after, there was an international randomised study of a novel way of giving paclitaxel, this nanoparticle-bound paclitaxel called nab-paclitaxel, and that was another randomised trial versus gemcitabine alone compared to gemcitabine plus the nab-paclitaxel. And you can see the results of these two trials. The FOLFIRINOX study showed this survival advantage for FOLFIRINOX versus gemcitabine, with the median survival going from 6 months as per usual with gemcitabine all the way up to 11 with FOLFIRINOX, and a hazard ratio for survival of 0.57, which in oncology is pretty significant. We don't normally see hazard ratios of 0.57. So that was really a major shift for us and an advance. The benefits of adding nab-paclitaxel to gemcitabine were still present and clinically significant, we felt, but not quite as great as FOLFIRINOX. But nab-paclitaxel is better tolerated, and so FOLFIRINOX is, being this 3 or 4 drug combination regimen, is really only for the real fitter patients in the metastatic setting, and we could give nab-paclitaxel to a few more. Comparing the two trials side by side, I guess the main difference, well, one of the main differences was the actual FOLFIRINOX study had quality of life data, and actually demonstrated that patients did maintain their quality of life more than they did in gemcitabine, even despite the higher toxicity. They maintained their weight, they had lower pain levels, they had better overall energy levels and less deterioration. There was no quality of life data from the nab-paclitaxel study, which was quite a big failure of that study, really. And you can see their median survival was that 11.1 months with FOLFIRINOX versus 8.5 with gem paclitaxel. So a little bit higher, even with all the caveats of cross-trial comparisons. So from 2011 to 2013, those two trials were published, and they then became our two standard chemotherapy combinations to use. And you've probably heard all about the era of targeted therapies in different cancers and how they've revolutionised diseases like melanoma and the such. Well, there's really been nothing in pancreas cancer except those two chemotherapy regimens until perhaps this year, when we'll see at the ASCO plenary. So this is clearly going to be a big deal. There's going to be a randomised phase 3 study of FOLFIRINOX chemotherapy, followed by either observation, which would be sort of standard, versus olaparib maintenance, so a PARP inhibitor, in patients with metastatic pancreas cancer with a germline BRCA mutation. And they probably represent about 5% of all patients, so it's a small subset, but we never really test it. But now this BRCA germline testing is becoming so much easier to test. It's $200 on a saliva test nowadays, whereas it used to cost thousands, and all the genetic counselling that went with it. Nowadays, we are getting much more easier access to germline BRCA mutations based on what we're seeing in ovarian cancer. And it really looks like this is going to be a positive study, otherwise it wouldn't be in the plenary at ASCO. So that'll be our first targeted therapy for pancreas cancer. Woohoo! But only in 5% of patients. So that's all I have to say about metastatic disease. What about resectable disease? So adjuvant chemotherapy, so that's post-operative chemotherapy for 6 months for pancreas cancer, has been standard of care now for probably best part of a decade, I guess, or even more. Started off with the SPAC study from the UK, showing that 5-FU chemotherapy was actually better than chemoradiation post-operatively. But mostly we'd been using gemcitabine because that was clearly superior to observation from this European phase 3 study, showing a 5-year survival of 21% versus 10% with observation. So it was still, obviously most people are still relapsing and dying even despite gemcitabine, but those rates are a little bit lower. And gemcitabine is pretty well tolerated on its own, so giving that for 6 months has been our standard for many years. The UK guys, they like adding capecitabine because of their study, SPAC4, which did show us modest improvement of adding capecitabine to gemcitabine, with 5-year survival going up to 29%. But it adds toxicity, and it's not really been overwhelmingly embraced by the rest of the world, I would say. But you can see in all of these studies that the number of patients completing the therapy is about half of those that start it. And I would say that all those patients actually getting pancreas cancer surgery, only half of those actually get to the stage where they get onto these trials. So it's only really then about 25% of patients actually get to finish adjuvant chemotherapy of all those who underwent surgery. So, you know, these Whipple's procedures, as David said, they're tough. Patients take a long time to recover. They're not often in a very good fit state to give adjuvant chemotherapy to, which has been one of the big barriers to getting the best treatment into these patients. They just come to your clinic and they're tired and they're just getting over the operation, and the thought of 6 months of chemotherapy doesn't fill them with great joy. And as David touched upon, the next big advance really was looking at FOLFIRINOX, so that same chemotherapy we now use in metastatic disease, in the adjuvant setting. And this was, as David said, published in the New England Journal last year. And it demonstrated really some astounding improvements. And this was first presented at ASCO last year. And really the audience was very, very impressed with the results. So again, you're seeing, though, that only about 2/3 of patients are completing therapy. But you're seeing a median disease-free survival now of 21 months, whereas in all those previous trials I showed you, it's about 12 months. So nearly doubling of that disease-free survival. And a median overall survival of 54 months, which is incredible, really, which is more than 4.5 years. I mean, some of that does reflect that after recurrence, these patients are getting a gem, nab-paclitaxel, or more chemotherapy to keep them alive a bit longer. But nonetheless, that really is quite an amazing figure. So just a bit more detail about this study. It was a fairly simple design, randomised 1-to-1 to gemcitabine, which, as I told you, was our standard of care for the last many years, versus FOLFIRINOX. Patients had to have a CA19-9 below 180. They had to have a post-operative CT to make sure they had no metastatic disease before they went on to chemotherapy, because these patients could relapse very quickly. And what we can see from the treatment completion is that far bigger percentage of patients in the gemcitabine arm were able to have a high dose intensity. So this is the dose intensity is basically a measure of how much chemotherapy you're able to deliver versus how much you wanted to. And you can see that for the gemcitabine group of patients, a lot more of them got a high dose intensity than in the FOLFIRINOX group. So there weren't a lot more patients in the FOLFIRINOX group were getting dose reductions, dose delays due to increased side effects. Nonetheless, despite those limitations of FOLFIRINOX, the efficacy was far superior. So as I said to you, the median disease-free survival was nearly doubled, and the 2-year survival went from 30.7% to 47%. So really quite a dramatic improvement, mirroring what we saw in metastatic disease, I guess. So that really leaves us with FOLFIRINOX now as our standard of care in the post-operative setting. So for patients who come to us after surgery, FOLFIRINOX is really first and foremost in our mind as what we'd like to deliver to patients. As I said, some really can't tolerate that, so in that case it would still be perhaps gemcitabine because it's got some effect, but for most patients we try and deliver FOLFIRINOX. But that leads us to the obvious question of what about the role of neoadjuvant therapy? If it's so difficult to give chemotherapy after surgery because patients are so stuffed by surgery, what about treating them at diagnosis preoperatively? They're fitter, they're treatment naive, and we can get the systemic chemotherapy into them earlier. We can attack micrometastatic disease, which we know is there in such a large percentage of patients, and we can get in and do that early. So it makes a lot of intuitive sense. And in other solid tumours, we know that neoadjuvant therapy is standard of care or a standard of care and no worse than adjuvant therapy. So it makes a lot of sense. And as David alluded to, it is the way I think the world's shifting. And another reason it makes a lot of sense is because this is quite a sobering graph from one of the adjuvant studies that I showed you earlier. So patients undergoing surgery for their pancreas cancer having adjuvant chemotherapy, dependent on whether you've got a positive or negative resection margin, between 20 and 30% are dead at 12 months. And these are not all comers having had surgery. These are patients who are well enough post-operatively to get onto an adjuvant chemotherapy study. 20 to 30% are dead at 12 months, so they're clearly not benefiting from surgery. They're relapsing and dying very quickly. So what data is out there for neoadjuvant chemotherapy for pancreas cancer? Well, there's no real large phase 3 studies yet. I'll go through briefly what there is. There's quite a number of single-arm phase 2 studies, and 3 are listed here. And what we can see is, generally speaking, when you give the neoadjuvant therapy for resectable patients, about a quarter are progressing during treatment or something bad's happening, they're not getting to surgery. And that seems to be quite consistent across the studies. This is the GAP study, which is our own study here in Brisbane and also in Sydney, led by Andrew Barber. This was preoperative neoadjuvant chemotherapy with nab-paclitaxel in 42 patients. Actually trying to look for an R0 resection rate of 90% was our hope, but we didn't really get anywhere near that. It was only 52%. There are a number of reasons for that. And again, you can see about 29% of patients progressed during preoperative treatment and never got to surgery. And a median overall survival of 2 years was similar to the studies I showed you just in the previous slide, and the median disease-free survival, depending on the resection status, was about 12 months. I think we're still trying to publish this study. I think we're up to the 4th journal now to try and get this damn thing published, but hopefully we'll get there in the end. So what about randomized studies of neoadjuvant therapy? So there are randomized studies. This was actually presented at ASCO last year. This was a Dutch study where they gave older treatment, so gemcitabine-based chemotherapy, not FOLFIRINOX. They either gave it post-operatively in the adjuvant setting after surgery up front, or they gave it with radiation, or before, then radiation, then after, and then surgery. So really it was a pre versus post-operative study. And what you can see is that, I guess as you may expect, in the neoadjuvant group, fewer patients are getting to resection because patients are dropping out during the preoperative treatment. So more patients actually going to resection in the immediate surgery arm. But of those going to resection, the R0 resection rate in the preoperative group was double compared to the immediate surgery group. So telling you, I guess, that you're maybe selecting better patients for surgery by giving them neoadjuvant treatment, and those getting to surgery perhaps really are the ones who should be getting to surgery and benefiting more from it. Likewise, in the survival curves, if you look at the intention to treat analysis, so that's all patients included and randomised, you can see that there is a strong trend towards a survival advantage for the green line there, the preoperative group, versus the surgery upfront group. P-value doesn't quite reach statistical significance, but there is a strong trend. And if you look at those who those who got resected, the actual the difference increases substantially in favouring of the neoadjuvant group. Again, to me, suggesting that you are better selecting patients for surgery by giving them neoadjuvant therapy. This data has not yet been published, but is again, I guess, another persuader that neoadjuvant therapy is the way to go. There is no randomised data of FOLFIRINOX yet in the neoadjuvant setting. There are some single-arm studies. This was probably the most quoted one from Harvard, where they treated 48 patients with borderline resectable pancreatic adenocarcinoma and gave them all 8 cycles of neoadjuvant FOLFIRINOX and then radiotherapy, and followed that with surgery. And these were not resectable patients, these were borderline resectable. And they actually found that 2/3 of the patients went to surgery. So that's 32 out of the 48 patients proceeded to surgery. The other 16 dropped out. But of those 32 that went to surgery, nearly all had an R0 resection. And the survival results are really quite encouraging. The 2-year disease-free survival is 55% and 2-year overall survival 72%. So really quite encouraging results for those 48 patients. But again, it's a single-arm selected, single institution study, but nonetheless encouraging data. So where does that leave us? What about upcoming trials? Well, the Americans are keen to do a randomised study of FOLFIRINOX given neoadjuvantly versus it all giving adjuvantly. I've just spoken about how much sense it makes to give the chemotherapy neoadjuvantly, and that's what our surgeons want. So how well this study will ultimately recruit, I'm not sure, whether patients or clinicians are going to be willing to randomise their patients to an upfront surgery arm and followed by adjuvant chemotherapy, because I think that more and more the world is moving to neoadjuvant therapy. So whilst it'd be lovely to have a large randomised phase 3 study like this to quantify exactly what the benefits are versus adjuvant treatment, I'm not sure it'll ever get completed, but we'll see. That's planned. This study is planned in the US. Another approach is to just adopt the neoadjuvant treatment strategy and compare which chemotherapy you're going to use. So this is a comparison of FOLFIRINOX versus gem/nab-paclitaxel, both given pre and post-operatively. So not a question of what's the strategy, but a question of what's the best chemotherapy to use in that setting. However, on a bit of a sobering note, we were involved in the large adjuvant study of gemcitabine versus gemcitabine plus nab-paclitaxel. So that's the other, as I said, the other regimen we use in metastatic disease. So a trial design exactly the same as the FOLFIRINOX trial design versus gemcitabine, but it appears that the results of this trial are negative. So the gem/nab-paclitaxel group of patients did not show an improvement in disease-free survival versus gemcitabine alone in that APACT randomised study. So that's going to be presented at ASCO in a couple of months' time. So we'll see what the exact results look like then, but perhaps looking like gem/nab-paclitaxel may not be beneficial in the adjuvant setting, and therefore these neoadjuvant studies that I just showed you may be thrown out, and FOLFIRINOX may be the only one that's left. So there are a huge number of ongoing questions. You're probably aware that immunotherapy has really taken the cancer world by storm over the last 5 years. Melanoma, lung cancer, renal cell, amongst many others. It's really changed the standard of care for many patients with those cancers. The checkpoint inhibitors, which are the anti-PD-1 antibodies, which is the main immunotherapy that we're using against those cancers alone, they just don't work against pancreas cancer at all. Unfortunately, but there's still trials going on looking at incorporating those checkpoint inhibitors with chemotherapy or perhaps with other targets. Incorporation of radiation into the neoadjuvant setting. So there is the master plan study is an Australian-led study that's got MRFF funding, and that's using FOLFIRINOX initially, and then randomizing patients to intensity modulated radiotherapy or not before surgery. So again, they're using that neoadjuvant approach, but asking the question, what's the role of radiotherapy, which is really, to my mind, a very vexed question. There's been numerous negative studies in the past, but maybe that relates to old radiation techniques. Maybe with intensity modulated radiation it will be different. I just don't know. But that study will run in Australia. And then there's the PARP inhibitors that I just go back one, thanks. Then there's the PARP inhibitors that I showed you before, and that looks like they're going to be a real game changer in the BRCA mutated subset of patients. So I think we're going to be checking for germline BRCA mutations in patients more and more. In fact, I've got a patient on chemotherapy right now who we know is germline BRCA mutated, who's responding extremely well to platinum-based chemotherapy. So hopefully one of these PARP inhibitors will become available for her. And there's also studies going on led by the Melbourne group of using circulating tumour DNA to predict outcome and predict the way in which treatment should go. So nearly all pancreas cancers have RAS mutations, so it's quite easy actually now to do a blood sample and pick up the RAS mutation in the blood, and that can tell you whether or not you've got residual circulating cancer-related DNA after treatment, and therefore give you an idea as to how effective treatment's been and maybe guide your adjuvant treatment. If you've still got the DNA present after 2 to 3 months, should you change treatment? So these studies are going on as well. So that's potentially a useful future biomarker. And that's it.
Any questions? Ruth?
Thanks, Matthew, for a great talk. The high dropout rate, is there any data that shows that even people who've started it do better, or are there any differences? Did they look at the outcomes in the people who'd actually had even part of the chemotherapy regime, a bit like the magic in gastric cancer?
Yeah, I think from that data I showed you with the FOLFIRINOX versus gemcitabine study, you could see how lower the dose intensity was, and that in part relates to them stopping early in the FOLFIRINOX arm, so they would have only got part of the chemotherapy cycles, and yet the outcome was still so much better. So I think yes, some chemotherapy is definitely better than none. Also in the post-operative setting, we know that waiting to start, it doesn't really matter that you don't start in 6 weeks or 8 weeks, as long as you should start a bit later, wait till the patients have recovered, and then once you start, they can actually tolerate a few cycles then is better. But I think that data there tells me that even just some chemotherapy is better than none, and even the lower dose intensity and with dose delays, etc., they still seem to be doing a lot better. Yeah.
I know you have some expertise in this, but what's the role of PET scanning in assessing patients with pancreas cancer?
Yeah, so we published on this a couple of years ago. So we recruited about 50 patients at the Royal Brisbane, 60, and showed that out of that 60 who all had a prospectively recruited patients had an FDG PET scan, 9 were found to have metastatic disease that other imaging modalities didn't detect. And so there was one lady actually who had mediastinal and neck nodes, which weren't picked up before that, and we were biopsied the mediastinal nodes, and one node was sarcoid and the other node was metastatic adenocarcinoma. and she unfortunately died within a few months. I remember she was from Rockhampton. So about 16% in that study of patients were upstaged by the PET scan, and therefore were rendered ineligible for surgery. So we found it useful in that study.
We don't use it routinely, though, do we?
We try to if we as much as we can in appropriate patients.
Thanks very much for a nice talk. My question is, you said pancreatic cancer is eventually going to be the second leading cause of death, cancer death. How is it going to happen? Because people are not drinking more, or what is the etiology, or how could it go around?
Yeah, I think that's probably a number of factors there. People are smoking probably less, supposedly, or at least in the West, at least in more developed world. So smoking's a big risk factor. It's a disease of the Western world. It's a disease of Western diet, Western lifestyle, obesity, diabetes. We know all those things are on the rise, and I think it probably, as much as anything, relates to that.
I guess two questions. One is, how much tumour regression are you seeing from now that most patients are getting neoadjuvant therapy before their surgery? How much tumour regression are you seeing, or what's the range of tumour regression? And secondly, when you get the tumour regression, is the surgery different when you've what was an inoperable tumour may become operable with clear margins? Is the surgery different in the patients who've had previously inoperable surgery when you convert the fibrosis from tumour stroma to sterile fibrosis?
Do you want to go first?
Yeah, from the surgery point of view, it's really difficult because unlike the neoadjuvant case I showed, most patients don't show radiological improvement, and actually most studies recommend not using radiological change as evidence for regression or lack of regression. And so for the most part, a lot of the trials, especially that one from Harvard with Christina Ferroni, they recommended that if you had other markers, so normalisation of CA19-9 or a lack of progression on neoadjuvant treatment, that you should explore. And so those patients, I know Matthew didn't show any of it, she showed the borderline resectals, but the group of locally advanced, so they've done these same studies in locally advanced patients, so that's traditionally unresectable. And if they're explored after, then a lot of the tissue is still surrounding the vessels. But as you say, when we send it for biopsy or frozen section, it's sterile. And you can't pick that preoperatively, unfortunately, on imaging for the most part. So in the end, you are often obliged to explore. I've had now two patients with that kind of story where, upfront unresectable, explored. One patient had a residual 9mm tumour despite having SMA invasion and portal vein invasion and all that kind of stuff on his preoperative imaging. And another lady had, all of her nodes had been sterilised and she still had a primary tumour. As far as what that does to survival, I think we still don't really know. There was a good trial out of Glasgow where they looked at their initial FOLFIRINOX group. They had a complete pathological response rate of somewhere between 12 and 15%. So no residual tumour visible, which we haven't really seen yet, but seems pretty amazing, and up to about 20 to 30% with at least good going regression on pathology. But pancreas, as you know, pancreas cancers are funny. They're so stromal. There's so much non-cancer cellularity to them that it's sometimes hard to judge. So in general, I think if we're on the path that we're deciding we're going to give these people neoadjuvant, then we're a bit obliged to explore and see what we have intraoperatively.
Yeah, just to add to that, so in metastatic disease with these modern chemotherapy regimens, we are seeing response rates much higher than we ever used to see, 25-30%. But I think the metastatic lesions do show a much higher rate of shrinkage in the primary tumour, which, as David said, is really very, very stromal and really a hostile microenvironment to try and get drugs into, which is part of the problem we've had with treating these cancers. So I think those primary tumours in the pancreas are much less likely just to shrink, Some do, as David showed that case, but many don't. And but you're still getting cancer cell kill, but just not seeing the tumour itself shrink because of all that stroma.
I think for my vibe on the next 5-10 years, and Matthew might have a different opinion, is it's starting to. I don't think, unlike colorectal cancer, there's really not going to be a solitary, broadly applicable treatment that's going to be good for everybody. I think we're going to just start picking winners, and I know. There's some patients, I think most of the gains we see, there's still some patients with pancreas cancer who do absolutely terribly. You see them in the clinic, weeks later they're dead, or maybe a couple of months later, and nothing we do for them has made a difference. And there's a group of patients who seem to do amazingly well with surgery, which is getting better, and then they belt through their chemo, and then they're still I've been back long enough now to have 3, 4, 5 year survivors, which is a bit unheard of from my older colleagues. So I think we are picking winners in some places. Whether that's going to be enough to lift all those median survival curves at this stage, I don't know. And maybe it's going to be a case of finding some subgroups who will do better with different treatments rather than a broad therapy across everybody.
Okay, great. Thank you, Matt. Thank you, David. If we don't have any more questions, I'd just like everyone, if we could all put our hands together, and a small gift from the Society for both of you for spending time out of the busy schedules. I don't know if it's any food. Why don't we find out? Thanks.